Good afternoon. I just want to first thank y'all for being here with us today, but then also welcome Dr. Celine Saulnier. She is our presenter today, as you can see. Dr. Saulnier obtained her doctorate in clinical psychology from the University of Connecticut, after which she completed a postdoctoral fellowship and then joined the faculty at the Yale Child Studies Center. At Yale, Dr. Saulnier worked closely with Dr. Zami Klin and Sarah Sparrow, investigating adaptive behavior profiles in ASD. In 2011, she relocated to the Marcus Autism Center and Emory University School of Medicine to help develop and direct a large-scale clinical research program. In June 2018, she's left Marcus to develop her own diagnostic clinic and consulting company, Neurodevelopmental Assessment and Consulting Services, and remains an adjunct associate professor at Emory. Dr. Saulnier has written 2 books, Essentials of Autism Spectrum Disorders Evaluation and Assessment, and Essentials of Adaptive Behavior Assessment of Neurodevelopmental Disorders. She's also the co-author of the Vineland Adaptive Behavior Scales, 3rd edition. So welcome, Dr. Saulnier. We're happy to have you with us today, and all of you who are attending, thank you.
Thank you so much. It is such a pleasure to be here and to present to you all. And I am now presenting from my own office, as you just heard that I have recently left the Marcus Autism Center. So I'm very excited about this new transition in my career, but still very excited to be affiliated with Pearson and to be providing these webinars. So I do have to disclose, because of my authorship from both the Vineland and the 2 books, I do receive royalties. And you have these learning objectives for the following webinar. So first, I'd like to start with just going over the diagnostic criteria for autism spectrum disorder in the DSM-5. So the hallmark symptoms of ASD include the social communication interaction impairments. And in the DSM-5, an individual has to meet all 3 of these criteria. So the deficits in social-emotional reciprocity, the deficits in nonverbal communication behaviors used for social interaction, and then the deficits for developing and maintaining and understanding relationships. So all 3 of these you can observe and see even as young as in the infancy years. Now, the second hallmark criteria for ASD are the restricted and repetitive behaviors. And these include those stereotyped and repetitive speech, such as echolalia or delayed echolalia, which we call scripting or stereotyped speech, the stereotypical motor mannerisms, so hand flapping, jumping up and down, finger posturing, rocking back and forth, those types of behaviors, or atypical use of objects. This would be dangling string and peering out of the peripheral vision, or getting down at eye level and moving objects back and forth to peer at them in that way. And then excessive adherence to routine, so need for sameness, wanting to do the same thing over and over in a certain pattern, and potentially patterns of verbal or nonverbal behavior that are ritualistic, and then highly restricted and fixated interests. So these could be any topic or interests, such as trains or mechanics or science or whatever it is, and they can change over time, and a person can have multiple interests at one time, but the atypical behavior is the fixation on it. And then finally, new to the DSM-5 for ASD is the inclusion of the hyper or hyporeactivity to sensory input. So this would be the individual who covers their ears because they can't stand the sound of even something as minimal as the humming of air conditioning or hearing a siren that's very faint to someone else, or seeking sensory input. This would be the children who slam their body into walls that are really seeking that sensation. So an individual has to have at least 2 of these 4 criteria in order to meet the whole encompassing criteria for ASD. And this can be current or by history, so it's really critical to do a very thorough history with parents or caregivers, because even if an individual doesn't present with these, because they're not highly frequent behaviors, so you might not see them in, let's say, the hour, 2-hour snapshot that you have with the individual, but they could have it by history. Then the criteria that is consistent with many of the other disabilities in the DSM is that symptoms have to be present in early childhood. This is specific to ASD. This used to be in the first 3 years of life, but now it's just in early childhood because we do know now that some of the symptomatology can manifest later in childhood, maybe between 3 and 5 years of age, and that the symptoms cause clinically significant impairment across contexts. Excuse me, this is very important because in order to meet the clinical diagnostic criteria, there has to be impairment that is pervasive across contexts. So it's important, again, when you're doing an assessment to ensure that you're asking about different contexts, not just the one that you're in. And then finally, the disturbances are not better explained by intellectual disability or developmental delay. And certainly because the criteria changed so drastically from the DSM-4, where there were subtypes of autism, into the current DSM-5, a pre-existing DSM-4 diagnosis still holds in good standing today. The clinical specifiers that we have for autism, these are very important for outlining for someone's intervention programming. So you as the diagnostician, if you can put as much of this information into the report as possible, it really helps the person who is then treating and intervening with the individual. So first, with or without accompanying intellectual impairment. So we will always assess one's developmental and or cognitive profile when we're doing an assessment so that we know, is this autism with or without accompanying developmental delays? And then we also want to know the level of language that the individual has. They can be anywhere on the spectrum from completely nonverbal or minimally verbal all the way to having full fluent speech, and then everything in between. And then is the autism associated with a known medical or genetic condition? We know at this point in time that there are well over 100 identified genetic mutations that are associated with autism. And so if one of these is known, for example, 22q deletion syndrome or 3q29 deletion syndrome or Fragile X or any of the associated conditions, this is important to know, not just for treatment planning for the autism, but also for the associated medical complications that come with those conditions, such as seizures or heart defects, etc. And then we want to know if there are other neurodevelopmental issues going on. So in the DSM-5, we now can diagnose ADHD with autism if the individual indeed has attention, hyperactivity, impulsivity, symptomatology that is above and beyond what we would expect for quote-unquote garden variety autism. And then finally, there is some research that shows catatonic symptoms with some individuals with autism, so this is why it's in a clinical specifier if you do see it. Then we have the severity levels, and what's nice about the severity levels is that they're all about the level of support that an individual requires in their intervention, which really ties into adaptive behavior, because adaptive behavior is all about independent performance of skills. So level 1 would be requiring support all the way to level 3, which is requiring very substantial support and then anything in between. So it's very important to designate where you feel the individual falls along these levels. So just to go over some of the current statistics on autism, and I apologize, I really need to update this slide given that just last month the new CDC epidemiological study came out that shows that autism is now in, I want to say 1 in 59 individuals. So it has risen just slightly since the 1 in 68. And the male to female ratio remains about 4 to 5 times higher in boys to girls, with the median age of diagnosis still being around 4 to 5 years of age for school-aged children who are predominantly white middle class. When we see disadvantaged populations, even though we're getting better at identifying, for example, African-American, Hispanic children with ASD, we are still doing a not so good job in relation to Caucasian children. So those African-American, Hispanic children, disadvantaged populations are usually diagnosed 1 to 2, if not several years later than Caucasian children. What's unfortunate is that we know we can identify autism very reliably by 18 to 24 months of age in most cases. So the fact that we have a 2 to 3 year discrepancy between when we can diagnose autism and when we are diagnosing autism is a problem that we still need to address in our society. So we still need to do a much better job at diagnosing autism earlier. Now, the comorbidity with intellectual disability remains about 30 to 40%, which is a change historically because 20 years ago, it was more like 70 to 80% of people with autism had intellectual disability. So there are many reasons for this change. Diagnostic substitution for one, meaning that 20 years ago, an individual that carried the label mental retardation with autism, usually MR was the prominent label, whereas in this day and age, if someone has intellectual disability and autism, autism is the primary label usually, which means that's just substituting one label for the other. However, we have gotten much better at identifying early developmental delays that go with autism when we diagnose early. So when we do that and we get intensive intervention for a child, we can remediate some of those early developmental delays, especially in the language area, so that we that because of that, individuals who would have gone on to have intellectual disability don't. And so we've probably moved the needle a little bit in that regard to the advantage. Now, the current CDC study showed that even if we're looking at just Caucasians, maybe 20 to 30% of Caucasians with autism have intellectual disability. If we're looking at African Americans, it's twice that. It's upwards of 44%. So that's something that we need to address, because why would African American children with autism have more of them have intellectual disability? And then in siblings with autism, we know it's a genetic disorder. And if you have one child with autism, the likelihood of having a subsequent child with autism is no longer just over 1% of the population. It's 1 in 5, which is a 20% risk. So 1 in 5 biological siblings will have autism. Another 1 in 5 biological siblings will have what we call the broader autism phenotype, meaning shadow symptoms or some symptomatology of autism, but not enough to meet the full criteria that we just discussed. And then another 1 in 10 will have non-autism developmental delays, language delays, cognitive delays, or both, which means about 50% of our siblings are vulnerable in their development to some degree. So we want to watch them very, very closely. So now talking about comprehensive diagnostic evaluations for autism, the way we do this, if it's state-of-the-art, we want it to be twofold. We want a very thorough developmental history with parents, caregivers, teachers, whoever's interacting with the child. And then we want direct assessment with the child, not just observation of the child, direct testing. So when we have both of these, then we have what's considered the gold standard. Now, assessment of adaptive behavior is part of a gold standard evaluation. It's pretty commonplace right now to conduct any measure of adaptive behavior when you're diagnosing autism, and we'll talk about why that's the case as we go along. So before we can really talk about diagnosing autism, we have to go over the diagnostic criteria for intellectual disability. So in the DSM-5, we have deficits in cognitive functioning, meaning having an IQ score approximately 2 standard deviations or more below the mean of 100 on most standardized tests. And then also deficits in adaptive behavior on standardized measures that usually have a mean of 100. So both of these delays have to be present to carry the diagnosis of ID, and then the onset in the developmental period, meaning usually prior to the age of 18. And then the severity levels now defined in the DSM-5 are more according to those severity levels, like adaptive behavior, rather than what previously was just IQ scores, so mild ID being an IQ range, for example. So now let's differentiate intellectual disability or cognitive functioning from adaptive functioning. So if we think of cognition as an individual's repertoire of skills, so their ability, what they actually are capable of doing. So these are both skills that the child was just born into the world with, as well as what they acquired throughout their development. So this is their capacity, their optimal ability. Adaptive behavior, on the other hand, is how a person takes a skill from that repertoire and applies it to real life when life demands it. So when life demands that behavior, can the person independently perform the behavior? So it's not their ability necessarily, it's what they do. It's what they perform with complete independence, and that means no prompts, no supports, no reminders, no help. So don't think of it of adaptive behavior as what a person can do. Think of it as what a person does do. There are tenets of adaptive behavior that date all the way back to when adaptive behavior was first defined in the early 1900s by Edgar Dahl, and that's that adaptive behavior is age-related. So earlier in development, a person has less adaptive skills than they do when they're older, and they acquire more skills. Adaptive behavior is defined by the expectations and standards of others because we live in a very social world, so it's what the world's demanding of us. Adaptive behavior is defined by typical performance, not ability, so it's the does do, not the can do. And what's really nice about adaptive behavior is that it's modifiable, and it can change over time, and it can change quite quickly. That's in contrast to cognition, which is relatively stable over time. So if someone, for example, receives intervention or lack thereof, or if they move from one place to another, or if they experience some type of trauma, anything can change adaptive behavior, that someone used to have a skill, now they don't, or that they didn't have the skill and now they do. And so when we measure adaptive behavior, you can see change within usually as quickly as maybe 4 to 6 months. And then what's also nice about adaptive behavior, it's the only thing in life really that solid average or adequate is the appropriate goal. Don't shoot for high expectations with adaptive behavior. We don't want to see above average or super high adaptive scores, and that's because we don't want, for example, a 5-year-old driving a car or roaming out in the middle of a city by themselves. That adaptive behavior is by definition age-related, so we don't want to be above one's age or cognitive level. Now, when we think of going back to the autism spectrum, there's so much heterogeneity in autism, so much variability that it's actually controversial, that people in the field are starting to think, how can someone who is completely nonverbal with substantial intellectual disability have the same description of autism as someone who's highly verbal and has superior cognition, and then everything in between, all be encompassing this label of autism. And so when we talk about low functioning, high functioning, and everything in between, we're usually referring to levels of cognition. So low functioning autism is someone that has cognitive impairment with autism, and high functioning autism is the absence of that ID. Now what happens is when someone has intellectual disability, they're more likely to have medical comorbidities like seizures, cardiac defects, associated genetic disorders, etc. Whereas on the flip side, if someone doesn't have intellectual disability and they have autism, they have more psychiatric comorbidities because they have more insight and awareness potentially into their disability. So they're more aware that they're struggling, more aware that they had a failed experience with their peers. And so we really want to make sure we're also assessing for these medical and psychiatric comorbidities along the way. Now, if we think of levels of adaptive functioning across the spectrum rather than levels of cognition, we can actually contribute to someone's outcome much better, because I think we do a very good job of identifying what adaptive skills are needed for someone with intellectual disability. So if I, as a psychologist, diagnose, ID, and whether it's a school-age child, adolescent, and that person is not fully dressing themselves, bathing themselves, feeding themselves, taking public transportation if they're a young adult, these are things that I am immediately putting into their treatment and intervention program, saying this is a priority that this individual needs to succeed in life. We're not good at doing that with high-functioning autism. someone without intellectual disability. We just assume erroneously that someone, because of their high cognition, high verbal ability, that they must know how to dress themselves, feed themselves, bathe themselves, get along in the world, when most of the time they don't. So we really need to think about these levels of adaptive behavior rather than cognition. And if someone, even on the high functioning end, might have those basic adaptive skills, they probably don't have the more sophisticated adaptive skills that need those building blocks earlier on. So maybe they can have a brief exchange, but they can't navigate the workplace niceties in order to not get fired and do something inappropriate in the workplace. So just to illustrate this, I wanted to show you a couple of video clips, and I hope you can hear it playing off of my computer. But this video, you'll see two gentlemen with autism. This gentleman here that you see has autism, and the other gentleman that you'll see has, at the time, was defined as Asperger's syndrome, highly fixated on prime numbers and math. Now, this gentleman has 2 master's degrees in math, and so my colleagues, this video was taken at Yale, thought it would be interesting to put them in a room together so that they could discuss their common interest in math.
I'm only a genius. Yeah, I'll say. I was originally considered a math major at Yale, and you're teaching me these things. So it's like maybe I'm smarter than the professors. Actually, I wonder how I could get a professor. I wonder if I could get a professorship in Yale in math. Well, stick with these guys. The whole thing is first you have to get through college, then even for grad school. Not always the easiest. Well, you know the 30. You know what? Well, no, I didn't want to put a number because you know the 30 and the 1709 could add 1 to the 1709, get 1710, and divide the 30 into it, so you would get the other factor, right? So that code was fine, so that somebody found the code book. But the thing is that I like that code is that if you did find a number that wasn't thrown in here, right? Yeah, I wonder how long it would take to break that. I actually knew the same one.
So the point here is that despite the high cognitive level and language level of these two individuals, they are like two ships in the night passing each other. They have very limited social communication skills. They are talking over each other. They are interrupting one another. They are not on the same wavelength. And neither of them is regulating their own behavior or their conversational partner's behavior by saying, for example, hey, stop interrupting me. Wait a minute, I wasn't finishing my thought. Stop moving around the room. Things that we automatically do to regulate our social interactions. Now, in contrast to this, I want to show you a 2-year-old and a 3-year-old of typical development who met 5 minutes before this video was taken so that you can see in contrast just how fluid social interaction is quite early in development. So there you see much more in sync social interactions. They're very contingent with one another. And in fact, the 3-year-old is so socially intuitive, she gets at eye level of her conversational partner. And then the 2-year-old is appropriately borrowing both speech and gestures from her conversational partner. We might not know what the topic of that conversation was, but they do, and they are very in tune to one another. So I don't want to say that we should be treating older individuals on the spectrum as if they're toddlers because they're missing these basic skills. But we do have to be cognizant of the fact that they are missing the very building blocks of social communication that toddlers possess. So we can't shoot higher than where they are when we intervene because we need to ensure that all individuals on the spectrum, regardless of language and cognitive level, have the basic fundamental adaptive skills. So when we assess for adaptive behavior, we're talking about the Vineland adaptive behavior here, and you see the 3 different versions over time, and we're currently at the Vineland 3. The Vineland does remain the gold standard measure of adaptive behavior, and it was developed to be a semi-structured interview with a parent or caregiver. And now, even though there is a parent form, the Vineland truly should be conducted as an interview whenever a person can conduct an interview, because that's how you elicit the most appropriate behaviors from all of the information that you're gathering as a clinician or as an examiner. So just to give you an example, if I just hand a rating scale to a parent and say, can you complete this on your child? And even if I do the best job of instructing them to remember, I want you to think about what your child does do, not what they can do, because this is all about their independent performance of the behavior, blah, 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 blah. By page 4 and item 125, they've forgotten all of those instructions that you gave them. So they're thinking, oh, can my kid do this? Can my kid do this? Yeah, I think my kid can do this. So they answer the question. Now, if I'm conducting the interview and I see a parent go, oh, I think my kid can do this. Yeah, I think he can do that. Then I can intervene and I can say, you just said your child can dress himself completely. About what percent of the time does he do that with complete independence, meaning you're not reminding him at all? Oh, well, like 10% of the time. No, he doesn't do it without my reminding him. So then you realize that you're actually scoring that item as 0 rather than the rating form would have had a score of 2, full credit. So when we give rating scales, we tend to get over estimates of adaptive behavior. This is specific to autism because we do see a discrepancy between the does do and the can do in autism. And in other disabilities, this might not be the case, so it might not be a big deal. But in autism, it is a big deal, and we don't want to overestimate and not get the appropriate intervention needed for the individual. So when it's possible to conduct an interview, that is the gold standard. So the Vineland has 4 domains: communication, daily living, socialization, and motor. In the Vineland 3, the motor domain is now optional. It goes up to age 9 now, but it's optional, so that the global adaptive behavior composite only includes communication, daily living, and socialization, even if you were to opt in to do motor. And then the Vineland has a maladaptive behavior index, so you can get scores on internalizing behaviors, externalizing behaviors, and then critical items like, for example, suicidality and other atypical behaviors. And so you have the option to do these in a comprehensive version or a new brief domain level version, and there are webinars just on the Vineland 3 that go into details on all of that. So now I want to talk about profiles of adaptive behavior that we see in autism. Now, there has been so much research on adaptive behavior profiles dating way back decades, and historically we would see that adaptive deficits were pretty global across the board for people with autism. And there used to be an autism profile, they called it, where deficits in adaptive socialization were the strongest area of deficit, which you would intuitively think given that it's a social disability. Now, more recently, we're seeing that the profiles differ depending on the cognitive level of the individual. So when we see individuals with autism that do not have cognitive impairment, we see striking deficits in adaptive behavior compared to their cognitive level, their age and cognitive level, with socialization usually being the lowest. However, in individuals that do have intellectual disability and autism, we're finding that adaptive behavior skills are usually on par with or even higher than cognitive levels or mental age, which is striking and in contrast to what we historically saw. And I think this truly does have something to do with the fact that we're good at intervening and making recommendations for adaptive behavior treatment and intervention when we see someone with significant cognitive delays. Now, of concern is that the research has been showing this gap between cognition and adaptive behavior in those without intellectual disability being greater in older versus younger individuals. And so the first research project that I did with Clin and Sarah Sparrow at Yale many, many years ago was on a subset of boys with autism who had no cognitive impairment. So if you look at this graph here, the dotted line is the average IQ for this sample. And we had a sample from Yale and a sample from Michigan with the same profile. And the red bar would be, this is Vineland scores. This would be adaptive communication. Green is socialization. Blue is daily living, and then the overall composite in pink. Now, we want to ignore the overall composite in pink because you see these discrepant scores here in the domains, and so this is just an average of highly discrepant scores. So what we want to look at is first, communication is so high here for these individuals, but it's high because within the communication domain on the Vineland, you have the subdomains of receptive, expressive, and written. Well, with people with autism, they love letters and numbers, and they love reading and writing, especially words that never change. So letters and numbers usually stay constant. So written adaptive scores are usually a relative strength across the spectrum. So if you actually remove the inflated written subdomain score, the communication domain overall falls down as low usually as socialization. Now, this gap between the dotted line cognition and all of these adaptive behavior scores in both samples was higher in the older kids versus the younger kids. Now, this is a sample of 8 to 18-year-olds. So we can't really say that the gap widens with age because it's a cohort. The 18-year-olds were different from the 8-year-olds. They weren't the same kids. We replicated these findings in a very, very large sample on over 1,000 individuals with autism ages 4 to 16. And this is the Simon Simplex collection. And here on the left, you see that the full-scale IQ, when the sample was broken into different age cohorts, so blue is 4 to 8-year-olds, green is 9 to 16-year-olds, you see there's absolutely no difference in their cognition. They had average cognition, and the older kids had the same IQ as the younger kids. However, the older kids had much lower adaptive scores across the board than the younger kids. So that was replicating what we had seen before, which was of concern. So now what we want to do is look at these longitudinally in the same cohort of individuals. So at Yale, we had a study where we did diagnostic evaluations on 2-year-olds and brought them back when they were 4 to confirm diagnosis. Now you can see that the red dotted line here is developmental quotient based on Mullen scales of early learning scores, that ratio IQ scores, that increase over time, and that's because IQ is not yet stable between 2 and 4. So they were still acquiring skills. These children that were diagnosed at age 2 also got a lot of treatment and intervention, so you can see the increase even in their adaptive communication scores. Now, we got a grant many years later to follow this same cohort of children up when they were 8, and you can see by then the children who were using their IQ at age 8, if you can follow me. So at age 8, those without cognitive impairment, their IQ was solidly average, and all of their adaptive scores were significantly lower than their IQ and age. Now, in the children with, so that gap is increasing with age. Now, in children with intellectual disability, you can see here that their adaptive skills are actually higher than their IQ scores, which were significantly impaired. So their adaptive scores are still substantially delayed from their age, but they're actually higher than their mental age. So what my colleagues and I are doing right now is we're following a sample of infants from birth who are high risk for autism, so they're biological siblings. Remember, we just talked about biological siblings are at a 20% increase for having this disability. So if we follow them from birth and we follow them for 3 years, we know their diagnostic outcome by age 3. So if you can follow this, we have a low-risk cohort that is a control group. And low risk means there's no autism in that child's family to the 3rd degree relative. So if we just look at those typically developing children from 12 to 36 months, their visual reception score on the Mullen, these are age equivalents, so that's why it's increasing over time. You're seeing that their nonverbal cognition is not only solidly average, by the time they're 36 months, it's way above average with these low-risk kids. That's their IQ, and here is their interpersonal socialization on the Vineland. Now, here's a gap. But remember I said you want adaptive skills to be adequate. You don't want them to be above average because you don't want that 2 or 3-year-old doing things that a 5 or 6 year old should be doing. So even though they have high cognition, they have adequate adaptive behavior. So that gap is parallel, so that's okay. Here are the children with autism who are diagnosed at autism by age 3. They have no difference in their nonverbal cognition. There's no significant difference between these two lines here. But here is their adaptive interpersonal scores. So that gap is widening as early as 12 to 36 months. And this is a paper with, this used to be my postdoc, Jessica Bradshaw, who now is a licensed clinical psychologist and now on faculty at the University of South Carolina. So what predicts good outcomes? So now there's been a lot of research showing historically in the field of autism that intact language and having no cognitive impairment are the two best predictors for good outcome in life. And good outcome is defined differently depending on the research study that you're reading, but usually it's defined as holding down a job, living independently, etc. So intact language, usually by age 5, and no cognitive impairment is you're going to be better than off than others. However, we're seeing, and I'll show you in the next couple slides, that adults with autism are not faring well even when they have intact cognition. So what is preventing them from having this quote-unquote good outcome? The research is now showing it's adaptive behavior, that even though they have intact language and no cognitive impairment, they have poor adaptive skills, and this is associated with their poor outcome. So if you look at this slide here, the best research on adults with autism is done by Patricia Howell in the UK. And her studies, if you look first on the left here, she was assessing outcome by these means, which basically, do they have a job? Are they living independently? Do they have successful social relationships? And only 24% of this group of adults with no cognitive impairment had a very good outcome, or good or very good outcome. The majority of them, if not the vast majority of them, had a poor outcome. And even more sobering, that when she followed this cohort up later in life, this percentage decreased to 18%. So something needs to be addressed here because we're going backwards. Now, research is finally starting to include assessments of adaptive behavior as outcome measures. Usually they're just part of the diagnostic classification. So a Vineland, for example, is given just to show that the child has autism, not using the actual scores on the Vineland to measure outcomes. However, treatment studies are now realizing, based on that research, that good outcomes associated with adaptive behavior to start using measures of adaptive functioning as outcome measures. And when that's done, the research is showing more and more prevalently that, yes, we can change outcomes if we actually address adaptive behavior. And one of these studies, if you look here, was a parent training study. It's a manualized parent training program, the Ruby Autism Network, and they showed that in 16 weeks, when you do this manualized training to address problem behavior in autism, one of the modules of the manualized treatment was addressing adaptive daily living skills. So they were specifically treating adaptive behavior in the 16 weeks. And so you can see here the solid lines here, if you can see that, are the treatment group, and the dotted lines are the control group, so that the treatment group did significantly increase in adaptive behavior skills over that 16 weeks, and even again at the follow-up later. So this just shows that in a very short amount of time, you can modify adaptive behavior. So with that, just want to talk about how we translate the test results into meaningful recommendations for treatment and intervention that can go forward to adult and good outcomes. So when we do a diagnostic evaluation and we as clinicians give a diagnosis of autism, that does not automatically make them eligible for a school eligibility, for example, for ASD or Social Security eligibility. You know, all of these have their own criteria. So for the IDEA Act, the law states that the needs of the child, they have to demonstrate an inability or impairment regarding access to the general curriculum. And with our quote-unquote high-functioning individuals, they're verbal, they have good cognition, so they can access the academic curriculum. They're going to sail through their classes. They're going to get good grades. However, it's the in-betweens. It's walking down the halls. It's lunch, recess, and gym. It's when they have to navigate social interactions. That's when they fail. So this calls attention to the social and adaptive functioning. So that actually is embedded in the law. So make sure that you're appropriately advocating for these particular individuals because they're the ones who will have the adaptive deficits. They have the capacity to be functional, independent adults, but they need to be taught specific adaptive skills, and this has to happen early, and it has to happen in the schools. So to give you a profile here of a 9-year-old boy with autism who has an above-average full-scale IQ, this is a Vineland profile. This was using the Vineland 2, but it could easily be the Vineland 3 here. You see within the communication, 81, 85, but that socialization is 68. So that's significantly lower than not only age and cognition, but even the other adaptive scores. And it's really being driven by interpersonal and coping skills. And like I said before, in the communication domain, you can see that the 14 of written when the 12 is the mean, that this is inflating the overall communication domain. And then the adaptive composite of 76, again, I usually don't pay too much attention to an overall score when there's that much variability in a profile. So you want to make sure that you are identifying these significant weaknesses and the discrepancies, not only to age, but to IQ and even between the domains. Then when you're writing up adaptive results, so for example, if you have a Vineland write-up, you want to provide the overall summary. So here are their standard scores. Here's the adaptive behavior composite. Make a qualifying statement of whether or not that global score is representative or not based on variability. And then you want to compare those scores to both chronological and mental age, so to their IQ. So you always want to make sure that the IQ assessment is part of this evaluation. Then you'll provide your descriptions of strengths and weaknesses for each of the subdomains and really focus on the areas of weakness that would be what behaviors that individual really should be doing that they're not. Don't focus on things that are below the basal or above the ceiling that you wouldn't expect them to be doing because you didn't even ask those questions. Really focus on those behaviors. Now, there might be a ton of behaviors that the person is not doing, and then it's up to the parents, caregivers, and intervention providers working with the individuals to prioritize which ones to focus on in intervention. So not necessarily use it as the examiner to make those priorities, but that hierarchy can be developed with those working most closely with the individual. What's nice is that the Vineland 3 has a new intervention guidance, and so when you conduct the assessment and you choose to include the intervention guidance in your printout, it is going to print out in order of the lowest to highest subdomain scores, all of the items and what their scores were. So you want to focus on the zeros and ones because that either the child is not performing the behavior with independence or only sometimes performing the behavior with independence. You want to focus on those, and then you can see them by content area. So for this particular child, you can say, oh, wow, there's lots of B's and C's that this individual didn't get full credit for. And if we look down here, B is developing reading skills and C is developing writing skills. So now all I have to do is write a recommendation for Johnny should work on developing reading and writing skills. So it does a lot of the work for you so that you can make these more content-based recommendations for intervention based on the behaviors. Now, if you do feel that there is one behavior there that is kind of an outlier, then you can actually just plug the behavior right into the report saying, teach this person how to do X behavior. Okay, and then transition planning. So the IDEA Act does recommend that transition planning for individuals with special needs start before the student turns 16. I would say start upon diagnosis. even if the child's 2, start thinking about transition planning, because we want to know what are the strengths of this individual that we can hone over time so that that person can be fully independent by the time they transition out of the school system. Because in most states, you go from very supported intervention, I know that's variable across states, but usually very supported and structured intervention, to absolutely nothing. There's a black hole in treatment and intervention for adults with special needs, and specifically adults with autism, especially our adults with autism that don't have cognitive impairment and can't get eligibility for something like SSI. So we want to ensure that we are fostering adaptive skills in all of these individuals, the majority of which will not have cognitive impairment from a very, very early age. We want to ensure that we're not only including the parents in this process, but we're including the person with autism themselves. If the majority don't have cognitive impairment, they likely can talk for themselves and talk about what their wants and needs are. So they should be included in their own intervention process, especially about what they want to be doing in life, and do they have a good insight and awareness into how they need to achieve their goals. So then, to summarize, start early, focus on their areas of strength. In autism, this can get tricky. If a person's area of strength is also their perseverative interest, you have to walk that fine line of not letting the interest become so all-encompassing that it's intrusive, that actually gets in the way from what you're trying to do, that you're trying to get them to, be more interactive with others, be more flexible, but now they're so involved in this interest that they can't disengage. So then, that might not be the best idea to incorporate their interest into their vocation, for example, but many individuals, you can do this, and it's optimal because there's the motivation right there, because they love whatever they're doing so much. These goals need to be included in the IEP and make them age and mental age appropriate. Make sure that the goals are measurable so that you can be tracking progress over time. You can't track progress if a goal is not measurable. Johnny should improve his social skills, for example, is the worst goal. There's nothing measurable about it, and it's way too broad. But Johnny should initiate an interaction with his peer 5 times a day, 5 days a week. That's measurable and very explicit. And you can always build upon that goal. You can add that it should be 4 exchanges within a conversation on the same topic, and then it can be he appropriately ends the conversation. So there are many ways in which you can do this. Like I said, involve the individual in the planning, identify any necessary accommodations. Many individuals on the spectrum have fine motor weaknesses, and so fine motor weaknesses translate into an inability to write. And then there's also complex abstract thinking deficits and executive processing deficits, so that means having difficulty with math. So have accommodations like provide a tablet or computer for typing, provide calculators, provide whatever is needed. And then exposing the individual to a variety of activities to prepare for successful transitions. And if post-secondary education, college is not the trajectory, then making sure that whatever vocational planning, that's set into place during the high school years so there's practice and involvement in the community. Now, what's interesting is, unlike other areas that you are treating and intervening, where there's manualized programs and type-specific interventions, there really aren't great resources out there that say, this is what we can use for enhancing adaptive behavior for individuals with special needs. Because adaptive behavior is just real-life skills. So when you think about it, it's really just more using common sense. Like, okay, the area of deficit is in toileting, so I'm going to look for resources specific to toileting. Or it's sleep issues, so I'm going to look for resources specific to sleep, or specific to social interaction, or specific to X, Y, and Z. So in a way, you're just drawing from commercial products that are out there specific to the area that you need. But there is this one adaptive living skills curriculum that looks pretty good that has these different areas, and it crosses the lifespan, which is very nice. So with that, I wanted to open up some time for questions. I just also want to acknowledge all of my mentors that I've had in my own clinical and research work on adaptive behavior, specifically Ami Klin, Sarah Sparrow, Dom Cicchetti, Diane Goudreau, and my research director at Pearson, John Camp. So thank you so much for your time and attention, and now I will bring it back for questions.
Thank you so much. I do have a few questions waiting for you, and I've also put a note in the chat box for people to email questions to me if we don't get to them so that I can get them to you for responses after this. We have about 9 minutes, so a handful of questions. One of them is regarding teacher completion of the Vineland 3. When there's a child who has a developmental level of less than 3, and the comprehensive teacher form doesn't feel appropriate for some of those students, someone was mentioning that they have utilized the interview form with the teachers, which would seem appropriate since the teachers are working on some of the skills amassed or covered in the interview form, eating and drinking independently, taking coat on and off independently, greeting, interacting, things like that. And so she was asking if that is indeed appropriate to use that comprehensive interview form with teachers who are working with students with a developmental level less than 3, or is there another suggestion?
Okay, so I'm going to give 2 answers to this. The first is that it's breaking standardization because the teacher form was not standardized as an interview, and the interview was not standardized with teachers. So you would have to qualify any results that you got because the norms wouldn't be matching the administration. That said, here's my clinical response. First, what different information are you going to obtain that you didn't get from the parent through the interview? And is it really information that the teacher has that's different than what the parent knows? If that's the case, then clinically I would say yes. If it's going to provide more information, more meaningful information that you need to really diagnostically or clinically conceptualize what's going on with this individual, then that might be the best way to do it. The teacher forms the behaviors themselves because of the developmental level of them. The more comprehensive interview will have some behaviors that go younger, and that would be my only reason for suggesting that. But whenever you can stay by standardization so that people reading your report can say that your findings are valid, I would say try to do that as much as possible.
Thank you. The next question has to do with the receptive language portion of the comprehensive interview form. This person is commenting that it appears that the receptive language portion also asks questions regarding expressive language. Many of the students at the school where this person works have a diagnosis of ASD with limited communication skills. Many use picture symbols, others use a dedicated voice output device in a structured setting, but few generalize these skills across settings. And so I think she's asking about how that is reflected in that receptive language portion of the interview form.
So I would just say for all of the Vineland, any type of augmentative and assistive communication devices or what have you, sign language, anything that's used with independence counts. And so if you read the manual, it makes that stipulation. So you would be thinking that not only within the receptive language domain, but throughout the Vineland. So if someone independently uses their PECs, for example, then you should be giving full credit for that behavior. If they need the prompt or the reminder to do so, then they shouldn't receive credit, if that answers the question.
Okay. Another one has to do with how diagnostically untreated ADHD can often mask ASD when young kids go to the pediatricians. When the child is later medicated, when their ADHD is medicated and under some control, then the characteristics of ASD appear again. He's asking if we're continuing to see that as a trend.
Oh, that's a good question. I'm not familiar with any research that shows following individuals over time or to the degree that makes that differentiation. And in fact, it would only have to be since the DSM-5 that we truly could do that type of investigation. However, I will tell you that in my own clinical experience, people misdiagnose both all the time, and thinking what's impulsivity in ADHD or inattention in ADHD is truly the autism symptomatology. So, for example, someone with autism who's fixated on whatever they're fixated on and is not responding to anyone in their environment when they call their name or give an instruction, that's not inattention, that's autism. That's overfocused attention. So any medication is not going to address that behavior. Impulsivity. So a person with autism who has no social buffer and no social awareness that what they're saying versus doing versus thinking is, inappropriate. They think something, they do it. They want to touch a female, they inappropriately touch a female. They say something and it's completely inappropriate, they just say it. It's not because they're impulsive and can't withhold the impulse to say that. It's because they have no social buffer and they're clueless completely to the fact that it's inappropriate to do or say. So until you can truly differentiate that in a good diagnostic assessment, then we wouldn't even be able to answer that question because I don't know who's misdiagnosing what from what end. And so in the way that if it's true ADHD symptomatology, this is someone who has autism, a social disability with additional inattention, hyperactivity, impulsivity, then of course someone's behavior is always getting in the way of seeing their true presentation. And in a lot of ways, when we do a diagnostic evaluation for the autism component, and someone's behavior is so erratic, and it might be disruptive behavior, not so much ADHD, but this person has never been taught a compensatory strategy that's appropriate to communicate. So they communicate through biting, hitting, decompensating, throwing, self-injury. And so we cannot make the diagnostic call until those behaviors are in check. So a lot of times we'll say this person has to undergo some treatment for these behaviors before we can really confirm the diagnosis of autism. So in that case, I would say to the person who's asking that question that could be true, that the ADHD is masking the autism and that the autism diagnosis is delayed because of the symptomatology. So that was a long roundabout way of answering that. I just wanted to get that diagnostic differential out there because it's happening a lot.
Oh, that was super helpful, though. It was a good response. Thank you. The next question is about thinking about using the Vineland with older adults and in group homes. So could you talk a little bit about who should be interviewed in those situations? And the second part of that question is there much research on the use of Vineland with older adults in group homes?
So I'll start with the easier question first, which is the second question. There's very limited research on adults in general. And so, yes, there is research on adaptive behavior in adults with autism. And in group homes, it's usually the residential provider or the instruction coach or whoever that knows that individual best. So when you're conducting it, the Vineland manual states that whoever is the respondent should know that individual for at least 3 months. And so you want to make sure it's someone who's working most closely with that individual that knows their behavior across contexts. Now, sometimes in the group home and, the residential person might know the residential aspect of that person's life, but the vocational coach knows their vocational community aspect of their life much better. So in that way, you might want to change respondents based on the domain that you're assessing so that you get the most accurate information. But it doesn't have to be a parent per se. It certainly can be someone who knows the person most closely. And oftentimes, even with kids, that might not be the parent. It might be a grandparent. It might be a foster parent. It might be someone else. Prisons, we see the same thing, that you're trying to figure out who's is it a correctional officer that works in the prison? So it varies.
I know that the Vineland is used quite often in those, in community mental health, in evaluations of older adults in group homes, and often one of the caregivers, one of the direct caregivers is the respondent. It is heavily used in that area. I guess we just don't know how much or if there is any active research around that right now.
Right.
Another question is about, so someone has asked, adaptive skills are said to be assessed by observed behavior, not by what the person can do. Behavior is widely seen as a function of ability, what one can do, and motivation. So do you think that discrepancies between ability and measured adaptive scores are really a measure of motivation? If someone doesn't have ASD, but is, for example, lazy, doesn't want to make his or her bed, should scoring reflect this as an adaptive deficit?
This is when I always throw my daughter under the bus. Absolutely. Because if someone asks me, can my daughter, who's 9, brush her teeth? Yes, of course she can brush her teeth. She's 9. She has, I think, average intelligence. If you ask me, does she brush her teeth without prompts, reminders, supports, or am I chasing her around the house and pinning her down and putting the toothbrush in her mouth myself? No, maybe 1% of the time, not even 0.05% of the time. So I would absolutely call that. I would call out my daughter for having an adaptive deficit in brushing her teeth. And the reason I say that is because you don't want that deficit to carry out into adulthood. There are a lot of lazy people out there, and myself included, where I'm not going to do something that I should be doing when life calls on it. However, if I were stranded on an island, am I going to do it when life calls on it? Yes, I probably am. So I probably will perform that skill with independence when I really need to. So that's the difference. Like, how much do you really want to worry about it? Do you think this person's lazy to the extent that even in emergency situations, that person's not going to do it, and then you have to intervene, or whether or not to just let it go, like my daughter.
You know, I just realized it's 2 minutes after 2. I was about to ask you another question. There's still a handful of really good questions. As I mentioned earlier, please put the question in an email to me. I gave you my email address, and I will get it to Dr. Saulnier for response. I'm sorry, we have gone a couple of minutes over, and we need to close out here. So thank you all very much for attending. Thank you, Dr. Saulnier. We're going to end the webinar.
You're welcome. Thank you, everyone.